Good morning. We're back at Be Kind Pediatrics this morning. It's back to school time and it's fall, and so we're seeing a lot of cases in New Jersey of enterovirus, and that's pretty typical for this time of year. So today we're going to talk a little bit about different causes of diarrhea in children. We're going to focus on acute viral gastroenteritis, what to do, red flag symptoms that maybe suggest something else, and when you really need to bring your kiddo in to see your doctor.
Welcome to the Beehive Doc Talks with Dr. Blair Rolnick. As a pediatrician and mother herself, Dr. Rolnick is here to answer your most pressing parenting questions and guide you through the tough spots.
So let's first talk about signs and kind of symptoms of acute viral gastritis and diarrhea in general, and what potentially could be causing that in your child. So whenever a parent calls me and they're saying that their child has diarrhea, I have a few questions for them. We're kind of at the top of my list. My first question really is there any blood in the diarrhea? Because bloody diarrhea really suggests a potential bacterial cause as opposed to a viral gastroenteritis. My second question usually is there any vomiting or fevers that suggest an infection? So if your child has diarrhea and they have vomiting and they have fevers, that really makes me think that this is an infectious cause. And then the third question really is, how long has this been going on? So typically an acute viral gastroenteritis or the stomach bug will last less than 14 days. If the diarrhea has been going on for more than 14 days, that's a more prolonged course of diarrhea. And then I'm wondering, taking a look at things like your child's growth chart and seeing have they been growing appropriately, because that kind of puts us in a whole nother category. For example, a child who's had prolonged or chronic diarrhea and they're also not growing very well, I start to think about things like IBD, endocrine problems. Could it also potentially be an immunodeficiency? So especially a very young child who's not growing well, who has diarrhea and eczema, I'm really thinking about more of a primary immunodeficiency, which is really outside of the scope of this talk. So we're really looking at children who have diarrhea for less than 14 days, who are growing well and otherwise healthy children. Another common question that I encounter from parents is, what if my child is just vomiting? So children who are just vomiting, I'm more careful about thinking or labeling them as an acute viral gastroenteritis or the common stomach bug. And the reason for that is that the differential for just, or when you think about the causes of just vomiting, it's a little bit broader, and there's some potentially scary things on that list. Like, for example, diabetes can cause just vomiting, appendicitis, UTIs, bowel obstruction, and many, many other things outside of the more benign stomach bug. And so when a child comes and they're just vomiting and they do not have the diarrhea, I'm a little bit more cautious about saying, okay, this is probably the stomach bug, and try to think about that case a little bit more cautiously. That's a kid I would probably want to come in and have examined myself and press on their belly and look at their back and really do a full physical exam, look at their vitals, look at their neurologic status and everything else to make sure that we're not missing some of those other things. Okay, so I said in the very beginning that one of my first questions is, what does the diarrhea look like? And if it's bloody diarrhea, I'm thinking, could this be a bacterial cause? So for children with bloody diarrhea, I also highly suggest that for me, that's a patient I would want to see in my office, because I'd like to do stool studies on them. I want to, again, examine them and look at their vital signs. And I'm usually sending off those stool studies because that is a child who may be appropriate for antibiotic therapy. And we'll talk a little bit more about that when we go into treatments for diarrhea in children. The other question that I think is important to ask is, has your child recently been on antibiotics? So antibiotics or antibiotic-associated diarrhea is a common side effect of antibiotics, but there's also a bacteria that can overgrow in your stomach when you're on antibiotics called C. diff. And so again, that is another child who, if they've been on antibiotics and they're having diarrhea, I would probably want to come in and see them and talk to them and hear a little bit more about what's going on. Parents often ask me about C. diff if they work in the healthcare field, if they have ever had an experience or a loved one who has had C. diff. And there's kind of a small caveat that people and parents should be aware of, and that is infants less than 1 can be colonized with C. diff. And so that's a population of children who I wouldn't recommend necessarily testing for C. difficile unless they you've done so in conjunction with a pediatric infectious disease doctor, and the symptoms really are suggestive of it. So let's go back to the more common presentation. That is a child with diarrhea that's non-bloody, that's lasted less than 14 days, who's otherwise healthy and a well child. So again, the most common cause of this scenario is going to be a virus. And that cause of the virus depends really on the time of year. So right now in New Jersey in the fall, we tend to see more enterovirus family. And then in the winter, we really see more norovirus as well as rotavirus. And rotavirus used to be the #1 cause of severe diarrhea in children until we started vaccinating for it. So the vaccination for rotavirus depends on the type. So if you're giving Rotatec, that is given at 2, 4, and 6 months. If you're giving Rotarix, that's a 2-dose series done at 2 and 4 months. And this vaccination is only for children less than 8 months old. So if for some reason your child missed their rotavirus vaccine and they're greater than 8 months old, they would no longer qualify for the vaccination. And since we started vaccinating for rotavirus, now we see a little bit more norovirus as the #1 cause of severe acute viral gastroenteritis. And so these children usually present with very severe diarrhea. They're a little bit higher risk for requiring hospitalization, and they can get really, really high fevers as well, especially with rotavirus. That is one virus that classically can cause febrile seizures. So it doesn't matter in the sense that there's no antiviral to treat them, but if a child has really severe diarrhea, regardless of the cause, and really high fevers, they're ones I would recommend keeping a closer eye on. Like at home, you should really be looking at as a parent, how much are they urinating? How many wet diapers are they making? Not just how many wet diapers, but what is the quality of those wet diapers? So if they make 6 wet diapers, and they usually make 6 wet diapers, but those diapers are very light and they're not as heavy as they usually are, that's important information. For your older child, you do want to kind of be more present and keeping a little bit more track of how often that they are urinating and how much they're taking in. And we'll talk a little bit more about oral rehydration and how to do that at home. So I think now is a good time to talk a little bit, again, if your pediatrician or your healthcare provider is really thinking or suspects that your child has a viral gastroenteritis, what can you do at home to keep them at home, and what are the most common complications of that? So by far, the most common complication of most viral gastroenteritis is going to be dehydration. And for that, really the recommendation is oral rehydration therapy. There are very few children who will benefit from IV rehydration. And the reason for that is even in various third world countries where children get very severe diarrhea, we know that the time to get an IV in delays the time of rehydration therapy. So even if your child is really dehydrated, it's probably wise to try to orally rehydrate them while you're waiting to get IV hydration therapy. And for that, the solution really matters for small children. So small children do not have the same glucose storage as adults, and so they require glucose in their oral rehydration therapy. Additionally, salt is very important for maintaining a healthy blood pressure. And so you want to make sure that your oral rehydration therapy has both salt and sugar as well as water. And this is something like if you're going to use a Stormade, I recommend something like Pedialyte because that contains the correct balance of water, sugar, and salt. If there is too much sugar in your oral rehydration therapy, that can actually worsen diarrhea. If there's too little or too much salt, that can cause electrolyte imbalances. And so I strongly recommend, if you have it available and your child will tolerate it, to use a commercial version of oral rehydration therapy. You can make oral rehydration therapy at home, and I recommend using either the WHO or CDC recommendations for creating an oral rehydration therapy. But basically, it's going to look like washing your hands, taking a clean source of 1 liter of water, and adding the correct proportions of salt and sugar to that solution and using that. If you're really concerned, like your child is making a little less urine than usual, they're having more than 3 bowel movements a day, call your pediatrician, ask for specific recommendations for how much oral rehydration therapy or a goal you should be using at home. It's most helpful to actually have the minimum. The more they're taking, they'll pee out. Often healthy children will pee out the extra fluids. We don't really worry about giving a child too much fluids unless they are very sick or they have an underlying cardiac or pulmonary problem. So for an otherwise healthy child, it's really looking at a minimum from your pediatrician. And that recommendation in pediatrics is based on their weight. That's why I say give your pediatrician a call and get an idea about how much you want to be replacing for how much they're losing. For an extremely sick child, this should be done in the hospital where they are actually measuring how much your child is losing and replacing that appropriately and watching their vital signs, etc. Two other things I really like to talk to parents about when their child is having diarrhea are dairy and sugar. So let's start with dairy. So dairy is lactose, so it's actually a type of sugar, but is broken down by lactase, which is the enzyme that makes that sugar into smaller pieces. Lactase is, if you think of your stomach like this, and this is the middle of your stomach and this is the lining, you have little projections like fingers into your stomach. And lactase is actually made at the distal tip of the fingers. And so whenever you have inflammation from any cause, but especially viral gastroenteritis, these tips slough off. And what happens is then the enzyme lactase is not being made. So children who particularly love milk, and then drinking a lot of milk, if they've just had a viral gastroenteritis, may not be making lactase. And what then happens is bacteria will take any undigested lactose in your GI system and break it down. And a byproduct of breaking that down is gas, but also osmotically, it creates more diarrhea. So just be aware that if you're giving your child tons of milk and they've just had an acute viral gastroenteritis, that may actually prolong the diarrhea. So if it's particularly severe, if it's been going on for a long time, sometimes I'll recommend just giving your child Lactaid while their gut heals so that they're at least breaking down the lactose. So oral rehydration that I was just talking about really applies for children who are greater than 1 year old. In children less than 1, we rehydrate them in a similar fashion. We're very careful about making sure they're getting enough and they're making enough wet diapers. But I would not recommend necessarily using oral rehydration solution in those children. Children less than 1 are better rehydrated using their formula or breast milk. And again, they can become temporarily lactose intolerant during the acute gastroenteritis, but unless it's very severe, I still recommend continuing to use their bovine-based formula if that's what they're on, as well as their human breast milk. If it's very severe, sometimes you can switch the formula to temporarily to a non-bovine based formula or a plant-based formula and then make the switch back once their stomach recovers, but that's a pretty rare instance. So moving along with treatments, outside of rehydration, which is really the mainstay of treatment, there also, if your child is vomiting, are antiemetics. There's been several studies published in looking at the use of ondansetron oral disintegrating tablets in pediatrics in vomiting and acute gastroenteritis. And it's really been shown to reduce the number of ER visits. It improves oral rehydration or the effectiveness of oral rehydration. And so there's lots of reasons to potentially use this medication if your child is vomiting. Usually I recommend not taking or prescribing more than 5 to 6 tablets, because if a child is requiring that much antiemetic medication, they should be reevaluated by their pediatrician to ensure that they are A, not becoming dehydrated, and B, for a really good abdominal exam. But short-term or short courses of this medication can be helpful. Again, it improves the effectiveness of oral rehydration and it reduces the number of ER visits for children. The caveat to that is that it really should only be used in children who are 2 years and greater. Children who have diarrhea or really vomiting in this section, when we're talking about this medication, children less than 2 have vomiting, really need to be seen by their pediatrician or physician and examined to make sure that they're, A, because they're smaller, they're higher risk for dehydration, and 2, to have an abdominal exam and make sure that there's nothing else going on that could potentially be more serious. So this is a great medication, again, for children who are greater than 2, who are vomiting and need a little more help staying rehydrated. a common medication that is used in adults. So there are other antiemetics out there that are more commonly used in adult medicine, but in pediatrics, we tend not to use them. A common one being promethazine. And that is because they have a lot of side effects. The most common side effects being something called an extrapyramidal side effect, which is really these medications cross the blood-brain barrier and they can cause neurologic side effects. And so we tend to not use them or shy away from them in pediatrics. So another common question I get from parents are about anti-motility agents or anti-diarrheal agents, and can they be effective in the pediatric population, or should they be using them in the trial, because many of these are over the counter. And again, I strongly do not recommend using this medication in pediatrics. One, they have a ton of side effects. And two, in the rare instance that your child does have a bacterial enteritis, it can actually make your child more sick. Specifically here, I'm talking about E. coli 0157.47. And that's a type of E. coli that causes something called hemolytic uremic syndrome. And it has been shown that the use of anti-motility agents when somebody has this actually can make their disease more severe. So I don't recommend that. The last question I often get is about the use of probiotics. And so the literature here is really mixed. There have been large studies that were published in the New England Journal of Medicine looking at probiotics that showed they were ineffective. There's subsequently been meta-analyses that are also randomized controlled trials that show that they are effective. And kind of my take here is I think we don't know enough about probiotics. It seems to really matter the quantity of probiotics, so that you take a lot, and the type and the indication. So the effectiveness for antibiotic-associated diarrhea in pediatrics is one probiotic. It's been shown, different strains have been shown to be effective for acute viral gastroenteritis. And so this is, again, one where I'd probably recommend you call your pediatrician and get a recommendation for a specific strain in a specific amount. But my overall take is they haven't been shown to be harmful, and there's not a lot of things that can really help acute viral gastroenteritis. And so I think it's worth a try for a specific strain in a specific amount. And the last treatment we'll talk about, again, is antibiotics. So antibiotics, I really only consider it in a child who either has bloody diarrhea, is very unwell appearing, or has recent travel, because those two things increase the risk that the causation of their diarrhea is bacterially associated. And for that child, again, I'm really getting studies to find out the specific type of bacteria, because if you have the wrong bacteria and you give antibiotics, again, specifically thinking about that strain of E. coli, you can actually make that child much more sick and worsen the severity of that disease. So it's really important to identify the bacterial cause, or if it's not bacterial, if you're thinking more parasitic cause, it's important to identify that parasite and or bacteria and use treatment specifically targeted for that. So that's one where I, again, recommend if your child has recently traveled, or if they have bloody diarrhea, if they're looking really sick, bringing them in and having those stool studies done. We now have PCR available to look at a lot of these bacterial causes. And so where we used to have to wait several days to a week to get an answer, now we can often get an answer in a couple hours to a couple days and start the appropriate antibiotic therapy. Again, with back to school happening, I think the last and probably the thing we probably should have started off with for treatment is prevention. So really good prevention. Most of these viruses and bacteria are spread by contact, meaning hands touching a surface that was contaminated, especially in young children who are using the bathrooms at school. If they don't really do good hand washing right after school, those doorknobs can get contaminated. High contact surfaces where they're changing diapers can get contaminated. So teaching your child how to really wash their hands with soap is the best prevention. Advocating for the schools to be wiping down those high contact surfaces a few times a day is also a great prevention strategy. And then for rotavirus specifically, having your baby immunized before they're 8 months old. So I hope you found this episode helpful, especially if you are struggling with diarrhea as your child has gone back to school. If you have any questions or comments, we'd love to hear from you. Please leave them below.
Thank you for watching The Beehive Doc Talks with Dr. Blair Rolnick. For more episodes and her practice, visit BeKindPediatrics.com, and don't forget to subscribe for more parenting tips wherever you get your podcasts. This information is for educational purposes only. It is not medical advice. Always seek medical advice from a qualified physician.